Hello, everyone, and good morning. My name is Destiny Braden, and I am the Development and Operations Manager at the TANGO2 Research Foundation, and this is my second TANGO2 Family Conference. Thank you all for your attention thus far. We will now be transitioning into our first panel presentation of the day, which will be discussing TANGO2 Deficiency Disorder and the brain, which is a topic that is on the top of many families' lists. So it is now my pleasure to introduce our next set of presenters who will be sharing their experience, expertise, and perspectives on this subject. Please join me in welcoming our presenters, Doctors Kimberly Hauk and Kuntal Sen, as well as TANGO2 mom, Robin Mitchell. Robin Mitchell is mom to TANGO2 warrior Hannah and son Benjamin. Robin is a 2023 retiree from a large insurance company in Michigan and currently a volunteer of the TANGO2 Research Foundation, serving as chair of the Outreach Committee and the Plymouth Canton Literacy Council. Please join me in welcoming Robin.
Hello, everyone, and thank you for having me here. I am Robin. I am mom to TANGO2 warrior Hannah, and Hannah is 31 years old. I'm also mom to Ben, who is not affected by TANGO2. He is Hannah's younger brother. Hannah, her dad, and I live in Michigan, United States of America, and Ben lives on the other side of the country in Seattle, Washington, USA. Although Hannah has a TANGO2 diagnosis, she's the only one in our family with a TANGO2 diagnosis. TANGO2 affects our entire family. We are in this together. I was invited to this roundtable discussion to provide a lived experience from a TANGO2 family perspective on the neurodevelopmental challenges of living with TANGO2. Hannah has faced neurological challenges throughout her life, but their cause remained a mystery for 27 years. She was diagnosed with TANGO2 only 4 years ago at age 27. Of course, while we wish we had answers earlier, we are very grateful that after 27 years, a diagnostic odyssey, we finally have 3 amazing things. 1, a medical diagnosis to help guide her health care. Number 2, a wonderful community of families like all of you from around the world to share stories and experiences. And number 3, researchers and the TANGO2 Research Foundation that holds the hope for new treatments and someday a cure. Over the next few minutes, I'll share the neurological challenges Hannah has faced over the years. And although this is Hannah's story, I believe many of you will recognize parts of your own journey in ours. Let's see. Okay, so this is Hannah. She's a 31-year-old woman who loves spending time with her family, including her brother, grandmothers, aunts, and cousins. 4 days of the week, she attends a workshop for developmentally and intellectually disabled adults, where she does volunteer work, attends classes to help her achieve life skills, and most importantly, socializes with friends and staff and gets out into the community. Hannah is a Special Olympics athlete. She's an active participant in our local therapeutic recreation program and is a member of a walking club for special needs adults. Every Wednesday in the spring and fall, she works at a concession stand at a local baseball park in our hometown to raise money for Special Olympics. She lives at home with her dad and me, but will eventually transition to a supported living arrangement with friends and staff. Another super important thing about Hannah is that for the past 4 years since her diagnosis, she has been using a mitochondrial cocktail that includes large doses of vitamin B5 and B9, and she has not had a seizure, a TANGO2 spell, an episode of ataxia, or another metabolic crisis since. So Hannah's neurodevelopmental challenges began early in childhood and have spanned her lifetime. They have impacted her ability to learn and process information, her behaviors, motor skills, and communication. Hannah was born in October of 1994. We spent a lot of energy during most of her young lifetime trying to understand what caused her developmental and intellectual disability, speech and language impairment, and the spells, or rather back then we called them episodes. The episodes appeared just before Hannah's second birthday in 1996. And were the first sign that she was developing differently. When Hannah was experiencing episodes, she would stumble, tilt, fall, become unable to walk, and she would drool profusely and lose the ability to speak. The episodes lasted 30 minutes or sometimes an hour or more. In an effort to try and identify why Hannah was having these symptoms, her primary care doctor ordered an MRI and an MRA to either diagnose or help rule out a variety of problems. One was to determine if Hannah was having TIAs, transient ischemic attacks, which manifest in a short period of symptoms like those of a stroke caused by a brief blockage of blood flow to the brain. Another was to see if she had arteriovenous malformation, which is a tangle of blood vessels that irregularly connects arteries and veins, disrupting blood flow and oxygen circulation. They also asked us lots of questions, including, is there any chance you and your husband, Hannah's dad, are related in any way other than marriage? And the answer to that question was no. Other tests included an EEG and a urine organic and amino acids test. All of the tests came back normal, and while we felt this was good news, it did not explain what was happening to Hannah when she experienced the episodes, what damage the episodes might be causing, what to expect in the future, and if there was a name or a treatment for it. We felt helpless, frustrated, deeply worried. What was wrong with Hannah? Would it become worse? What was happening to her body when she had an episode? Was it causing brain damage? Hannah's unexplained health problems caused a lot of anxiety. At one point, her pediatric neurologist suggested she might have a condition called episodic ataxia and prescribed Diamox, but this diagnosis didn't really seem to fit Hannah, and although she took Diamox for many years, it did not stop the episodes from occurring. Hannah's strange symptoms were a mystery, and they remained a mystery for 27 years. When Hannah was born and up through her first 2 years, we thought she was a typical toddler because she achieved all developmental milestones appropriately. When we witnessed that first episode when she was 20 months old, we hoped it was an anomaly and would not happen again, but it did happen again and again and again, repeatedly and consistently on a weekly basis over the next 4 years when Hannah was 2 and 3 and 4 years old. We kept track of the episodes by logging what she had eaten, what she was doing when they happened, and whether or not she was constipated. We also noted in our tracking log descriptions of the episodes so we could better describe them to her primary care doctors and her neurologists. I recently found my handwritten notes from 30 years ago, and this is what I wrote to describe the symptoms and what the episodes looked like. Limp leg, falling down, drunk walk, numb tongue, dizzy, difficulty standing, limping, stiff leg, drooling, tilted walk, stiff neck, vacant stare, slurred speech, weak legs. The episodes were a significant part of Hannah's life from age 2 throughout the next 5 years. These were years where crucial development should have been happening. Hannah's days were interrupted by the mental fog and the physical limitations brought on by the episodes. Instead of the important work of developing her executive functioning skills and other important development like self-awareness, self-control, self-regulation, Hannah's world was disrupted and stalled by the episodes. While the episodes did not cause Hannah physical pain, they were clearly sucking up her developmental energy and putting all of her crucial infant and toddler developmental progress on hold. Having a child with an undiagnosed illness was stressful. Beyond watching Hannah struggle through each episode, there were quieter heartbreaks. By age 3, the children she had met as infants in the baby room at her daycare were moving on to preschool, and while Hannah remained in the baby room because she was not developmentally ready. Seeing her peers move ahead while she stayed behind was deeply painful to us. Other significant neurological signs that after age 2 that indicated that Hannah was not developmentally progressing were when she was 3, she was diagnosed with speech and language impairment, and testing by our local school-based special education program showed she qualified for services because her IQ was tested at 67, and that was considered cognitively impaired. Also, she was developmentally behind in her peers in peer relationships, toileting, and fine motor skills. In addition to the physical symptoms of the episodes, Hannah began having frequent, intense tantrums that seemed beyond what we would expect for a 2-year-old. It often felt as though she were frustrated and overwhelmed by her challenges and by her inability to move forward developmentally. By age 3, when she became upset, she sometimes lashed out at her dad and me by hitting and spitting. Her punches didn't hurt us physically, but they left us deeply sad and confused. We knew something was wrong, but we didn't know what it was. We did not know why this was happening to Hannah, and her doctors didn't have answers either. This was the mid-1990s when the Human Genome Project was still underway. Whole genome sequencing was not yet available, and genetic testing was neither common nor widely accessible. Also, TANGO2 would not be identified as a genetic condition for another 20 years. When Hannah was 5 in 1999, she became a big sister Ben, and around that same time, the episodes inexplicably tapered off, occurring only monthly, and then over the years, only occasionally, several times a year. We don't know why they occurred less often. We didn't make any changes to our care for Hannah or in her diet. Over the years, however, other health conditions that impacted Hannah's neurological development included amblyopia, lazy eye. When she was 5 years old, and in her teenage years, she began having tonic-clonic seizures, a few every year, even after starting Lamictal and then Keppra. And she also experienced myoclonic seizures, or we called them hand jerks. And when she was 24 years old, during a routine primary care workup, we found out she had hypothyroid disease. So she started taking Synthroid for her underactive thyroid. In 2010, when Hannah was 16, her neurologist suggested we try chromosomal microarray analysis, which is a type of genetic testing. We hoped that this test would give us some clues about what was happening to Hannah, but unfortunately, the results were inconclusive. We wanted a diagnosis for Hannah to better understand how to optimize her care, to give us a guide path for possible treatments, to know what to expect in the future, and to connect with other families who had children like Hannah. However, we eventually accepted the mystery and focused on ensuring Hannah's ability to live her life to her potential, enabling her to have a happy, safe, and full life. Hannah's diagnostic journey ended in January of 2022 when she was 27 years old and experienced a life-threatening metabolic crisis. While the crisis was terrifying for all of us, the silver lining was that it prompted the use of whole genome sequencing that led to the TANGO2 diagnosis and started Hannah on a much healthier therapeutic path. This is how the metabolic crisis came about. In the fall of 2021, Hannah was 27 years old, and the spells started again. She experienced ataxia, drooling, inability to talk. The spells lasted 30 minutes or sometimes an hour or more. We're not sure why Hannah started having them again after so many years of spell-free living, but we suspect it was stress, constipation. The re-emergence of the spells after many years without them was a huge red flag that something was wrong. And something was definitely wrong. After consulting with her neurologist and drawing a blood sample, we learned that her liver numbers, ALT and ALST, were high. The day after the neurology consultation, Hannah went downhill fast. She became so weak and sick so quickly that we knew we had to get her to the emergency room. The ER doctors were puzzled by her symptoms and initially thought she was weak and tired from having had a seizure, but finally, after 13 hours in the ER, she was admitted to the observation floor. The observation floor doctors and neurology consultants didn't know what to do to help Hannah. They had no idea why she was so sick, and especially unfortunate was a decision to withhold her anti-seizure medication and all IV fluids for the next 20 hours. until the point at which she was in status epilepticus and had to be rushed to the neurology ICU by rapid transport. She was admitted to the ICU, where she stayed 11 days and ultimately 2 months in the hospital recovering. And during Hannah's 11-day visit to the ICU, here are the new words I added to my vocabulary. Rapid sequence intubation, a run of SVT, supraventricular tachycardia, episodes of sinus tachycardia resolved with doses of IV metoprolol. She received multiple boluses of lactated ringers, experienced pulseless ventricular tachycardia, and subsequent defibrillation and a synchronized cardioversion. She received amiodarone, a high-risk medication used for heart arrhythmias. She had a central venous catheter inserted. She had additional runs of ventricular tachycardia, septic shock, and persistent elevation of lactate gases, hyperammonia, hyper-CK anemia, and metabolic acidosis. She had a 3-hour run of intermittent hemodialysis. And before Hannah's crisis, I didn't know the definition of any of these procedures and conditions, and I would have been very, very happy never have to become familiar with any of these terms. But Hannah lived through this crisis thanks to the amazing neurology ICU staff, and in large part to biochemical pediatric geneticist who was on call the night Hannah arrived in the ICU. Based on Hannah's medical history and current health status, the geneticist suspected that Hannah was experiencing complications due to either some type of mitochondrial disease or a rare genetic disease called TANGO2 Deficiency Disorder, which she told us was a genetic condition discovered in 2016 by doctors and researchers at Baylor College of Medicine in Houston, Texas. Whole genome sequencing was initiated to confirm the diagnosis. In the ICU, we spent 11 long days before being shocked at what had just happened and staring at Hannah, who we could barely recognize. She was not moving and was minimally conscious. We wondered what kind of permanent neurological damage had been done. Would Hannah still be Hannah when she made it through this nightmare? The whole genome sequencing results would not be available for 2 weeks, and in the meanwhile, the geneticist suggested that we check out the TANGO2 Research Foundation, which was a new organization started by parents in Connecticut who had a child with TANGO2, and a family Facebook page to get connected with other families. Eager for more information about this condition and what we might be facing if Hannah recovered, we pulled out our cell phones and found the information and began reading. The website's description of symptoms experienced by individuals with TANGO2 matched Hannah so well that we knew even before the genetic testing results were available that this was Hannah. Mystery solved. We were excited, scared, thrilled, relieved, and hopeful. 2 weeks later, the test results did confirm it, after 27 years of searching for answers, that Hannah did indeed have TANGO2 Deficiency Disorder. The test also confirmed that her dad and I were both carriers and that we were not related. And thank you for laughing. That was just to see if you've been paying attention. So Hannah slowly improved and was moved from the ICU to a neurological step-down unit. She had surgery to embed an ICD, implantable cardioverter defibrillator, to address the potential for future ventricular tachycardia. And because the whole genome sequencing uncovered a genetic variant, which is consistent with a diagnosis of long QT syndrome 1. As she slowly woke up from the horrible neurological shock over the next 2 months in the hospital, we watched hopefully to see if Hannah was still Hannah. And she was. Slowly, she came back. She smiled at TikTok videos made by her brother, Ben. She began using a whiteboard and dry erase marker to spell simple words and tell us things that she wasn't able to say. The nurses played her favorite ABBA songs and braided her hair and polished her fingernails, things that made her smile and then laugh. She got mad and cranky at me and her dad when we came to the hospital every day to sit with her. She got back her feistiness, rebelliousness, when she realized she had an NG tube that was threaded down her nose and into her stomach. Yes, Hannah was becoming Hannah again. Thanks to the care from her biochemical geneticist and some of you in this room, we finally had a diagnosis, and Hannah was on the road to recovery. Hannah has since regained most of her pre-metabolic crisis abilities. However, the one area where she appears to have had a permanent setback is her speech and language skills. She has apraxia of speech, we suspect from damage that occurred during the crisis, and she struggles to verbally communicate even more than before the crisis. So, to wrap up, the overwhelming feeling we had upon getting the news about Hannah's diagnosis was gratitude towards Hannah's doctors and amazement for the wonders of science. We always knew Hannah was special, but we had no idea how truly unique she was. At the time, in February of 2022, she was only one out of about 100 or so individuals around the world who had been diagnosed with this rare condition, and she was the oldest at that time at age 27. So although Hannah finally had a diagnosis, which was amazing, unfortunately, we learned that TDD had no cure, and since it was only identified in 2016, still much remained to be learned about the condition. But even so, having the diagnosis gave us so much. For example, a sense of power and control, because now we had a name and a path to pursue for Hannah's care. We had a name for Hannah's symptoms that allowed us a means to search for information. We had access to the newly formed TANGO2 Research Foundation. We had access to other families living with TDD in a family Facebook group. We had a few published studies to help us learn more about TANGO2 and the potential to participate in the TDD Natural History Study from researchers at Baylor College of Medicine. So finally, the great news is that Hannah has not had spells, seizure, or another metabolic crisis in the almost 4 years since she was diagnosed and started taking a Mito cocktail that includes the B5 and B9 vitamins, and she also takes a daily dose of Miralax to help prevent constipation. So the TANGO2 diagnosis has given us hope that in the future there will be better and early identification of infants and children with TANGO2 to help begin interventions early to avoid the most disrupting and dangerous symptoms of the disease, hope for future treatments to alleviate the symptoms, address the potentially degenerative nature of the disease, and someday a cure. So thank you, everyone, for listening to our TANGO2 story, and thank you to everyone in this room for the work that you have done and you continue to do to support my family and families around the world affected by TANGO2. And thank you. All right. So now I would like to introduce our next speaker, Dr. Kimberly Hauk. Our next speaker, Dr. Kimberly Hauk, is a pediatric neurologist at Texas Children's Hospital and assistant professor in the Department of Pediatrics, Division of Neurology and Developmental Neuroscience at Baylor College of Medicine in Houston. Her clinical practice focuses on medical and surgical management of refractory epilepsy with special interest in genetic and structural causes. She is a member of the multidisciplinary TANGO2 research team at Baylor College of Medicine and has contributed to natural history study publication, review articles, and practice guidelines. Welcome, Dr. Hauk. Thank you.
All right, thank you for the invitation to speak to the TANGO2 Research Foundation, and especially to Dina for encouraging me and making sure I get my deadline. So I'm going to talk about understanding the TANGO2 brain from acute and chronic effects to pathways forward. No disclosures. So our objectives for today are to define seizures and epilepsy, to recognize a seizure emergency and implement seizure first aid, to analyze the natural history study data to gain insights into seizures, brain imaging abnormalities, and crises, and lastly, and most importantly, to advocate for TANGO2 warriors through information and collaboration. So I know I'm talking to a mixed audience here, but I wanted to start with the basics. So what is a seizure? So a seizure is defined as abnormal, meaning excessive and synchronous release of electrical activity in the brain that causes temporary changes in how a person moves, feels, or thinks. Seizures can take many different forms, including whole body convulsions or shaking movements, or changes in awareness or behavior, so staring spells, for example. So where the seizure occurs in the brain determines what the seizure looks like. And interestingly, or what a lot of people do not know, is that 1 in 2 people in their lifetime will have a seizure. So that's a pretty high number. And then we'll discuss after that what seizure versus epilepsy means. So common types of seizures in TDD, for the most part, we've seen generalized seizures. These affect multiple areas or the entire brain all at once. Some words that you might see and what Robin mentioned what she learned when Hannah experienced her first were myoclonic. So these are brief body or limb jerks, tonic-clonic, which are we also call convulsions, or the old word for it was a grand mal seizure. Atonic means loss of tone, or some people may describe them as a drop attack. And then absence are those typical staring spells. Seizures can also be focal, meaning that they begin in one area of the brain. And so you might see jerking just of one side of the body, or a lot of times it's hard to determine the difference between an absence, which is a generalized affecting the whole brain, versus a focal is only affecting a certain part of the brain, but you can still have staring off and impaired awareness. So what's the difference between a seizure and epilepsy? So epilepsy is the neurological or brain condition that causes people to have recurring seizures. It's typically diagnosed after 2 or more unprovoked seizures more than 24 hours apart. And this is the classic technical definition, so apologies for that. But it also can be diagnosed if you've had 1 unprovoked seizure, but with a high probability, meaning more than 60%, which is the general population, of recurring seizures. So if you have a genetic condition that predisposes you to seizures, or if you have a structural abnormality that also predisposes you to seizures, you can have a diagnosis of epilepsy after just 1 seizure, or if it's a specific epilepsy syndrome, which I won't go into detail. And approximately 50 million people worldwide have epilepsy, which is 1 in 26, which also seems a lot higher than we realize just walking around with everybody around us. So what to do if your child has a seizure? If your child has never had a seizure, that's great. I hope that continues, and we're doing our best to try to prevent seizures in the future. So this is from the Epilepsy Foundation, which each state has their own epilepsy foundation. So I do recommend looking at their websites. So the first, number 1, is to stay. So stay with the person until they are awake and alert after the seizure. And that might take a long time. So you'll obviously, as parents, you're going to stay with your child until they are feeling better. You also want to time the seizure. So note when it starts. We always tell this to families and parents, like, to stay calm. I'm sure it's much harder in the moment, but try your best to stay calm. And then if this happens to somebody else in the community that you're not familiar with, check if they have any medical ID. If your child has seizures, there's a lot of online, you can buy them on Amazon, medical IDs, which you can scan a QR code and it will bring up their medical history on that. Step 2 would be to keep the person safe. So if I were to have a seizure on here, I would not want to be on top of this platform, but putting you on the ground, so you're not going to injure yourself. If there's any sharp objects nearby, try to remove those from the area. And then turn the person to their side if they are not awake and aware. So if you're having a full body convulsion, you want to turn to the side so that the excess drooling does not block the airway. You don't want to put anything in a child's mouth or in a person's mouth if they're having a seizure. That's a risk for injury there and blockage of the airway fuller. If they're wearing tight clothes, you want to loosen those around the neck. If possible, try to put something soft under their head. And then we'll skip down to what not to do. So don't try to restrain somebody having a seizure. Just kind of let it run its course. Typically, seizures will last about 1 to 2 minutes. We'll talk about what to do if it doesn't. Stop in about 2 minutes. Or 2 to 5 minutes. And then if your child does have seizures, obviously keeping the rescue medications with you is important just in the case of an emergency. So what is a seizure emergency? So a seizure emergency is defined if it lasts longer than 5 minutes, which is what we call status epilepticus. If a seizure occurred repeatedly or rapidly without return to baseline, we call those clusters, or if this is out of the ordinary for your child. So this can be a sign of a possible crisis that's occurring. We do know hypoglycemia or low blood sugar can cause seizures. And you or I, if we injected ourselves with insulin, had hypoglycemia, we could have a seizure. But we know that in our warriors that they're at risk for hypoglycemia with prolonged fasting, and that this hypoglycemia, the low blood sugar, can also cause seizures and brain injury long term if it's prolonged. And then abnormal heart function can also cause brain injury. So if you're having an arrhythmia, that backing to that the pump analogy, that your pump's not working properly, that can cause, if it stalls, it can cause clots that go into different parts of the brain, or the brain's not getting enough oxygen because it's not getting enough blood flow, which carries the oxygen. I think I skipped over one. Oh, there we go. Epilepsy also has some treatment challenges. So in my field, I deal with kids who have medically refractory or drug-resistant epilepsy, and that means that they continue to have seizures despite 2 or more medications. And actually 1 in 3 people with epilepsy, 1/3 of those who have epilepsy will develop drug-resistant epilepsy. So that's my patient population. Just knowing in the TANGO2 population that vagus nerve stimulation is an option. So if your child is already on 2 medications, still having frequent seizures, that VNS can reduce the amount of seizures and also the complications from seizures. And also, I'm sure most of you are aware, especially in the medical community, that the ketogenic diet is contraindicated, meaning it's harmful. In TANGO2, it's a high-fat, low glucose or low carbohydrate diet, and so that can actually precipitate a seizure, and is how one of my patients, we found out his diagnosis. Status epilepticus is also one of our treatment challenges, and as Robin mentioned, that can be a complication of a crisis. It's defined as a continuous seizure longer than 5 minutes, or recurrent seizures without return to baseline. And I want to stress there's a high risk of brain injury with status epilepticus, so we want to treat that aggressively. And what have we gained knowledge from the natural history study? So incidence of seizures, as we learned yesterday with Dr. Miyake's talk, 50% of our warriors have had a seizure, at least one in their lifetime. The median age at first seizure was 1.95 years, and that the range goes from 2.4 months with the youngest to 23 years. In my data set, I saw a 42-year-old. I'm not sure if that was correct or not, but I think that was the patient that Christina talked about with that video yesterday. In terms of MRI findings, this was from the original natural history study publication in 2022, which showed that we had 54 participants that had an MRI at the time of the 72 that were in the study. 32% were normal, 35% were abnormal, and then 6% had an MRI, but we don't know the results because a lot of this is what you guys collect from your hospitals, which we know it can be difficult to get medical records from. And then looking into seizures and crises. So this is a quadrant plot which shows, so basically a crisis. So has the warrior had a crisis, yes or no? And then a seizure, does the warrior have a seizure, yes or no? And so in the ideal world, we want to be down in this right lower quadrant with no seizures, no crises, doing well, healthy. And so that has happened in 21% of our cohort of 112 patients that we have data to date. On the other hand, this is kind of the not so good scenario, this left upper quadrant has had a seizure and has had a crisis. We've had some patients, warriors who've had a seizure but have not had a crisis up in this right upper quadrant, and then who've had a crisis but no seizures down here on the left. And so what we've seen is that, we don't have conclusions from this, but it's observations, and that's kind of our next steps are, does a crisis predispose you to seizures, or does a seizure predispose you to a crisis? Are your chances of one or the other higher? And so it does seem to be a little bit higher with if you've had a crisis, if you've had a crisis, then you're more likely to have seizures. And then if you've not had a crisis, so that's only 30% in this quadrant who've not had a crisis, but have had a seizure. So this distribution is like 2/3 versus this one versus crisis and no seizures. So it seems like something might be going on with one or the other. And it's in the database, Some individuals have had a seizure first and then had their crisis, even years later, and some have had the opposite, where their crisis came many years before and then didn't develop seizures until later. And kind of highlighting that there has been a lot of variability in seizures and epilepsy in our warrior cohort. So there's obviously the 21% that have no seizures at all and no crises. There's some who've only had seizures in the setting of a crisis. There's individuals who have epilepsy, and then a subset of those, about a third, who have medically refractory or drug-resistant epilepsy. And what's great about our natural history study is that we have international, multiple families and families with multiple siblings inside of those. And I think there's a lot to gain from that. And so there are a total of 19 sibling sets in our database. 8 of those, there's 8 sibling sets who have at least one with and one without seizures. So it'll be interesting to see if you have children who more than one affected, if there's any difference. We saw yesterday with that plate of food, how the older brother had a relatively well-balanced meal with some vegetables snuck inside, and then the little girl who just had mac and cheese. So we have 5 sibling sets who both have seizures, 1 sibling set who neither have seizures, and then there's some that we don't have enough information on. And then the big question, which I get from my patients and their families, and obviously from all of you, do seizures damage the brain? So typically the thought is that brief, rare seizures do not cause damage, but seizures may be a sign that something more serious is happening. Not that a seizure isn't serious, but it can be a harbinger or a sign that there is a crisis that's happening, which is in the body, or there can be other issues going on in the brain. So metabolic crisis or a cardiac crisis, and we've established that cardiac crisis occur in the setting of metabolic crisis, but you can have a metabolic without the heart involved. So as I mentioned, hypoglycemia or low blood sugar can cause a seizure. It can also be a sign of a crisis. Hypoxiglycemic encephalopathy, which is another big medical term that I'm introducing to you, or HIE, is the lack of sufficient oxygen or blood flow to the whole brain. So this can happen if your child has a really severe arrhythmia and we're not able to pump the blood effectively to the brain, and the brain is basically starving. The whole brain is starving for blood and therefore oxygen. So that can cause damage. And then stroke. So whether that's a small area with the lack of blood or oxygen, either if the heart's not pumping properly, it forms clots when there's stagnant blood, kind of alluding to that pool analogy. We need a filter, we need a good flow, and so if that flow is not happening, then things get stagnant and they can cause a stroke. And then there's damage is greater with longer versus shorter seizures. So that concept of status epilepticus, we want to treat aggressively and correct the inciting factors to fix the crisis that could help the brain. And also don't let the doctors that you see assume that this is the normal for your child. If it should be. They should treat that aggressively. And then there's also some cumulative effects of seizures. So medically refractory seizures, you want to treat responsibly. So with anti-seizure medications, try to reduce the amount of seizures. And then just in general, from just epilepsy across different conditions, they have seen progressive brain volume loss and declining cognitive trajectory with recurring seizures, and that typically happens over years. And so this is a quote from one of our big journals. It's called Epilepsia, but Epilepsy Currents is more of the review and the commentary. But it says across both experimental and human domains, it remains difficult to separate progression caused by the underlying primary etiologies. So in our case, like TANGO2, what are those cells doing under the microscope, and kind of what's the inherent thing due to TANGO2 and what's from the recurring seizures. In the interest of time, I'm going to skip over these, except for there is one talking about that earlier talk that we had about the cerebellum and the Purkinje cells. This individual on the brain MRI does show some mild cerebellar atrophy. The cerebellum, oops, there's my alarm, is the structure here. And so how can I protect my child from future seizures? So we want to manage appropriately with anti-seizure medications. Avoid medications that can cause arrhythmias. If you have a question about what those may be, you can always ask your neurologist. If you have an epileptologist, that's even better. Those are neurologists who are specialized in epilepsy, like myself, especially if your child has medically refractory or drug-resistant epilepsy. Limit triggering factors. So we want to promote adequate sleep and rest, manage stressors such as illness and fever, try to treat those appropriately. Even psychological stressors can sometimes promote seizures. And then last is to provide adequate nutrition and supplements. So we have seen that B vitamins, especially B5 and B9, have shown to prevent metabolic and cardiac crises. And we think and suggest, and what you're telling us, is that they also may be helpful for neurologic symptoms, including spells or episodes, seizures, and development. So more hope for the future, just shining a light. Obviously, we want to conduct more research on how early and optimal B vitamin supplementation affects brain and nervous system health in TDD. So that enforces the importance of early diagnosis and treatment. So the earlier that we can start the vitamins is that can we prevent any deterioration, or if there is something going on that's damaging the cells that we don't see on a day-to-day basis, but is happening on a microscopic level. And then the natural history study, the importance of participation and collaboration. Specifically with Baylor work is where I work. And so this are some quotes. One is from a well-known educator. It says, "Every child deserves a champion, an adult who will never give up on them, who understands the power of connection and insists they become the best they can possibly be." And then children, I would say children with special needs or children with TDD are like stars. They may not always shine in the same way, but still light up the world. And so I want to thank the conference organizers. This was me back in 2019 when we had our very first conference. It was just a hotel in Houston, and especially to Dr. Miyake and Dr. Leilani for introducing me to this group. And that was my daughter in 2022 when I brought her at 10 months old to this conference. Unfortunately, they couldn't be here today, but this is them spring break on our Disney cruise. So they're definitely Disney fans, and hopefully 2028, I guess, is when I'll be able to bring them. Thank you. All right, and then our last speaker for this session will be Dr. Kuntal Sen. He is the co-director of the Neurogenetics Clinic in the Division of Neurogenetics and Neurodevelopmental Pediatrics at Children's National Hospital. He is one of the few physicians in the country with dual training in neurology and clinical genetics, which affords him a unique expertise to diagnose and manage patients with complex monogenetic neurological disorders. Dr. Sen's clinical expertise is centered on providing long-term, holistic, and family-centered care for patients with mitochondrial diseases and other ultra-rare neurometabolic disorders. Dr. Sen's research focus is on multimodal neuroimaging and neuromonitoring in inborn errors of metabolism. Please join me in welcoming Dr. Sen.
Good morning, everyone. Hope you all have had a wonderful time in Orlando, making new connections and reconnecting with old ones. This is my first TANGO2 conference, and I'm so grateful to be a part of this family. As you heard, I'm a clinician. I'm both a pediatric neurologist and a clinical geneticist. And I have had the privilege of taking care of TDD patients back in Michigan and now in Washington, D.C. So this disorder is very close to my heart, and I am grateful to be a part of this mission to find a cure. So, in Dr. Haug's lecture, we discussed seizures and MRI data from the natural history paper. And in my segment, I wanted to briefly review developmental profiles in patients with TDD, and also the importance of collaborating with neuropsychologists and social workers. And then lastly, explore some emerging questions and the direction in which research is headed in neurosciences. So every rare disease starts with the first reported patient, which is known as the index case. And that tells us the classic presentation for that condition. But with time, more patients are reported and studied, and that tells us the full spectrum of the disorder, from mild to moderate to severe. And that is exactly what Dr. Miyake did in her natural history paper. She studied the largest cohort of patients with TDD, including 73 patients from 57 families across 17 countries. And this was the paper she published, and the data collection is ongoing. So, looking at the developmental profiles of those patients from the natural history paper, most of them were born full term after uncomplicated pregnancies. 77% of them had normal infancy and feeding, but about 19% had feeding difficulties, and 13% were noted to have a poor suck. The early development was typical for most patients up till 4 or 6 months of age. And around 12 months of age is when parents noted the first sign of delays. And the median age for walking in this paper was 16 months. Unfortunately, with metabolic crisis, many of these patients had regression in their skills, and 6% never achieved the ability to independently walk. 97% of the patients had some form of speech and cognitive delays, and it was noted that their speech from a receptive perspective was better when compared to the expressive part. Looking into this further, all parents reported some amount of functional impairment, and 12 patients had formal IQ testing, and the average IQ in the cohort was 65. 7 patients had developmental profile using DP4 scale, and 2 patients were below average, and 4 were very delayed. Spasticity, which is muscle tightness, and walking problems were almost universal. And while many patients were able to walk independently, some required assistive devices such as walker and So speaking of social workers and neuropsychologists, I wanted to briefly touch upon advocacy for adolescents and adults with TDD, and we'll learn more about this from Dr. Murali's session later this afternoon. So first of all, there is the Americans with Disabilities Act, and that requires reasonable accommodations, which could be in the form of modified duties and schedules, and protects against disability discrimination. Then there's Social Security, which is financial support for adults with disability, and this is based on functional impairment and the annual household income. And then there's also guardianship versus shared decision making for patients who lack decision making capacity. And this is a legal process through the court and requires medical documentation. So some things to think about as our TDD warriors are growing up. Also wanted to touch upon sleep and driving, which I think are 2 important aspects. So many patients with metabolic disorders experience insomnia, both sleep onset and maintenance types. And this has been studied in other metabolic disorders such as urea cycle disorders. And the management we do is stepwise. We start with sleep hygiene and behavior strategies, followed by melatonin, and then proceeding to prescription drugs if needed. And then for us as neurologists, we should be proactively assessing fitness to drive, especially in those TDD warriors who have seizures and epilepsy. And also to keep in mind, motor and vision limitations can impact vehicle control and road awareness. And then executive dysfunction in the form of attention issues or processing speed can also impair safe decision making. Which brings me to some of the research questions which we came up with at the session yesterday. So can we partner with neuropsychologists to systematically study the attention, the executive function, and memory issues in our TDD warriors? Also, how do the developmental trajectories differ in different TDD cohorts? For instance, those who got early initiation of vitamin B versus those who did not. Those that have 22q11 deletion versus those who have the mutations. and also the ones who had prolonged hospitalizations and cardiac arrest versus those who did not. Also, can we systematically study the sleep patterns and the caregiver burden in families taking care of individuals with TANGO2? So we all have heard of these TANGO2 spells. What we know about them is that these are sudden episodes of ataxia or muscle weakness or altered mental status, and they can often be triggered by illness or heat or constipation. We also know that starting high doses of vitamin B5 and B complex appears to reduce the episodes and the frequency. And there was a study done by Dr. McKenzie and Dr. Hewitt, which is about to be published, where they analyzed videos of these episodes and found that they are a combination of ataxia, which is balance problems, and dystonia, which is sustained muscle contraction. I think moving forward and looking at the future, we might be able to use advanced neuromonitoring to understand better what exactly happens in the brain during these TANGO2 spells. For example, functional near-infrared spectroscopy can be used to look at the brain oxygenation, and amplitude-integrated EEG can be used to look for changes in the brain activity. And we were talking, Mike and I, we might also be able to use artificial intelligence to break down what exactly happens during these episodes. The other question that I have personally had is, what do these TDD brains look like? And I know Dr. Haug shared some of the data from natural history paper, but we might be able to study these even further. So, for example, diffusion tensor imaging can be used to understand the integrity of white matter pathways in the brain. MR spectroscopy can be used to study brain energy metabolism and chemical composition for individuals with TDD. And FNIRS and fMRI can reveal differences in brain activation and oxygen utilization during various cognitive and motor tasks. And then lastly, we need to do systematic education and advocacy research. And that means we need to develop structured pathways to support transition from pediatric to adult healthcare systems. We also need to create practical resources to help families navigate issues such as disability, guardianship, and social security. And we also need to spread awareness about TDD at larger meetings such as American Academy of Neurology and Child Neurology Society. And that's something that Dr. McKenzie and I are working towards, so stay tuned for more info. And I think that's all I have. Thank you so much for inviting me and for being a wonderful audience. Just wanted to thank the clinical team at Children's National that help us take care of rare disease families.